That's an excellent point. Thanks, Steve. I think what we should actually discuss also is that there's a number of upfront approaches. So saying in a patient that has advanced stage disease, and we'll say that they're healthy, not significant comorbidities, three of the more common upfront regimens would be ABVD, BIACOP, as per the German group, and Stanford 5. And I'm just wondering, let's just go down through the panel, is out of these three regimens, what do you use and why, and what don't you use and why? Let's start with Steve, please.
So certainly for standard risk patients, my standard is ABVD. I have a soft spot for Stanford 5. I trained there, and the first 75 patients I treated in my life with Hodgkin all had Stanford 5, and most of them did quite well. But I think we have enough randomized data now to show that ABVD is at least equivalent, allows you to avoid radiation in more people, so that's my standard. For patients with really high-risk disease, greater than 4 risk factors.
Do you use the international prognostic?
For advanced stage.
Okay.
That's when I'll think about adding in BIACOP. Fortunately, now we have some clinical trials which can give us some different options in those patients. BIACOP is a much more difficult regimen, at least in my hands, but for really high-risk patients, we'll consider it.
So do you feel that the benefit of maybe achieving a higher CR rate definitely outweighs the potential long-term toxicities seen with BIACOP, secondary malignancies, et cetera?
Yeah, I think there's a group of patients, we think of Hodgkin as a very curable lymphoma. I think there's a group of people who it really looks like their cure rate's going to be down at 50%. And I think once you get into those ranges, I think we can do better. And I'm much more worried about Hodgkin than I am about long-term toxicity for those truly high-risk patients.
Excellent. Anas, what's your opinion?
So, and I agree with Steve. And my default still ABVD outside the clinical trials. In clinical trials now, as you know, there's Echelon 1, which is randomizing patients to AVD, brentuximab, versus ABVD. I mean, there's data about BIACOP, of course. It wouldn't be wrong to use it. It wouldn't be my default to use it even in high-risk patients. And I can argue about different clinical trials and outcomes. There's at least one clinical trial from EORTC that showed even high-risk patients, really the added value of BIACOP. And again, it could be questionable depending how you look at the data. So my default still, I would go with ABVD even in high-risk patients unless there's reason not to do that.
So let me ask you just an extension to that, Anas. So you have a patient that you have a high-risk patient. BIACOP is very toxic, and maybe even the patient you discuss it doesn't want it. In your mind, you know that you probably don't have a great chance of a high chance of a cure. Would you ever consider taking a patient at high risk, say they achieve a CR, but you're concerned, would there be cases where you consider maybe putting them doing an autologous stem cell consolidation in some patients or not? Or would you just wait until they relapse, watch them closely, and then take them to salvage therapy?
I would not do that either. I mean, again,
Okay.
this has been done over and over again in many other curable cancers like diffuse large B-cell lymphomas.
Yes.
There's no question that upfront intensified treatment can give you prolonged progression-free survival,
Right.
but make no impact on survival. So the question is, should we subject all these patients to intensive therapy or wait for those who would relapse and offer them more intensive therapy? It's different strategies, I think.
Very good. What do you
Well,
feel?
we're going to agree more than that. My default would be ABVD, and in a high-risk patient, I might discuss BIACOP or think about it. I'm not necessarily sure I would push it, but it would be a discussion.
Andre, any
My
questions?
approach is very similar to Steve's, it's not identical. BIACOP, no doubt, is more active regimen and cures more patient, but it's also no doubt it's much more toxic. So if you apply as a blanket BIACOP to a lot of patients, you end up over-treating and exposing more patients to toxicities, while if you do ABVD and more patients relapse by a magnitude of 10–15%, many of them can be salvaged with then high-dose therapy autologous transplant. So I'm very selective in patients. I can probably count on one hand that I use BIACOP, younger patients, international index 5, 6, and above. And that's my approach.
I think it's also, but I think what's coming is very interesting as well, is that by choosing an initial therapy, what's be very interesting is utilizing some tools at hand, for example, PET scan. So a number of novel trials that are being proposed now is that it's actually kind of interesting. You start intense and you back off, or you start less intense and you rev up. And what I mean by that, very simplistically, is that patients that could be started on trial, with, for example, if you start with BIACOP, you get 2 cycles. If the PET scan is still positive, one would continue on with aggressive therapy. However, if it turns negative, there are studies we're looking at switching over to ABVD, and the opposite. You can start with ABVD, and if one actually, a PET scan is negative after, say, 2 cycles, You will then continue ABVD, however positive, then you rev up and go to. I think that's really good that we're starting to utilize these tools. So we're not committing patients necessarily. It's not ready for prime time. I'm not recommending it be done in the community, but I think it's very exciting that that type of approach is to give patients what they need, not too much or not too little, kind of like Goldilocks. I think that's the future. It's going to be great if we can do that in all types of lymphomas, and I think that's what's coming.
Right, but Myron, it's really important to point out outside clinical trials,
Absolutely.
PET-directed therapy, especially for advanced stage Hodgkin lymphoma, has really no proven scientific efficacy.
Right.
Changing treatment based on PET positive and negative. So it should be still restricted to clinical trials. It should not be widely used outside clinical trials.
I can only more than agree with that, and I think that also the other problem with PET scans is that one has to utilize what criteria we're using to call them positive and negative. And in particular, that right now the best studies are doing, they have central review of the PET scans using only a limited number of individuals reading it. So, in addition to that.